Hello, everybody. Thank you for joining the session live. Today's topic in GI physiology that we would be having is on technologies other than manometry in assessing esophageal dysmotility. Where do we stand? And the topic would be discussed by Dr. Shrihari Anikindi, sir. He has already done a beautiful talk on our show. So he has been invited again to give this wonderful talk and little more assessment into some future and newer technologies in assessing esophageal dysmotility. Thank you, sir, for accepting the invitation. And I would also like to thank Dr. Ready Stock for making this event possible. Over to you, sir.
Yeah. Thank you, Prashanth. And again, congratulations to you for this wonderful initiative. I think this is one of the rare avenues in India where people talk and discuss about motility and motility studies. This apparently is a niche or a newer area in the field of gastroenterology. And I think it does have a lot of potential considering the number of patients of motility disorders that we all see in practice. So today I'll be discussing about some of these technologies that are likely to come up in the future. We have had extensive talks on manometry and how do you use them for diagnosing esophageal motility disorders. But the future might incorporate a few of these newer technologies, and I think in maybe a year or so, we should be able to see and more and more of these modalities being talked upon and being actually seen in practice. So let me start off this talk. I bring greetings from Sir Ganga Ram Hospital, New Delhi. I'm a consultant gastroenterologist over there, and my primary focus of interest is GI motility and advanced endoscopy. Dr. Prashant, my slides are visible?
Absolutely, sir. It's visible. Good to go.
Yes. Yes. So we all know that this modality of esophageal manometry, we all use it very frequently, and it is the gold standard for diagnosing esophageal motility disorders. Most of us use it, most of us have it, and we are all aware of it, right? But it is not always that it's easy to do a esophageal manometry because several times the patient tolerance may be an issue because esophageal manometry has to be done in an awake patient where you are putting this catheter transnasally and patient may not cooperate. Especially this is true for children, for very elderly and uncooperative patients. Esophageal manometry also may not diagnose all motility disorders. I'll give you an example. There is an entity called ineffective esophageal motility, which is picked up very frequently when you do a motility study, but you don't know what is its relevance. You also have a subset called functional dysphagia, where you have done all the motility studies, patient has dysphagia, but you don't know the reason for dysphagia because all the existing motility studies have come normal, right? And one most important thing that manometry does not do is that it does not represent the transit of bolus. So looking at this very practically, see, it's important to understand that what we are actually interested or what the end result that we want is that the bolus which has been swallowed should transition across the esophageal lumen into the stomach. If that is not being achieved, then that is what leads to a clinical significant disease, right? Clinically significant disease, clinically relevant disease. Whatever be the motility disorder, whatever shows up on your manometry may or may not represent what is happening to the actual bolus transit in the esophagus. So to clarify things, when we do a manometry, all that we are seeing is the contractions of the esophagus. We don't see anything about what is happening to the movement of the food bolus that has been taken. This has to be very clear in everybody's mind, right? So we do have certain alternatives to manometry, which may or may not be exploring some of these avenues. So you have the endoflip, that is functional luminal imaging probe. You have the capacity to also do an impedance study that is called multi-channel intraluminal impedance, which can be done along with the manometry. Most of these impedance studies that we now conduct are usually with the pH study and not with the manometry study. But mind you, the manometry systems also have the capability to incorporate impedance systems within them. How they help you, I'll come to that later. And obviously, there are other studies like barium, which has been there since long. But now manometry has overtaken as the primary modality to check for esophageal dysmotility. You also have an entity called esophageal scintigraphy, which has not become very popular because of availability issues and because of the expense, right? So first, let's talk about endoflip. So endoflip, the full form is endoluminal functional lumen imaging probe. That is the flip. That is a functional lumen imaging probe. So how flip works, so for that, first we need to understand the principles of esophageal peristalsis. So basically, there are two types of peristalsis that occur, or rather, there are three types of peristalsis that are seen in the esophagus. We are interested in two of them. The primary peristalsis is when a person swallows certain food. The deglutition initiates a coordinated wave of peristalsis which goes from the upper esophagus to the lower esophagus. So this is the peristalsis which is initiated by swallow, right? But there is also an entity called secondary peristalsis. So what is secondary peristalsis? This is not initiated by the swallow, okay? But this is initiated by certain events like a reflux, or sometimes there are some retained contents in the esophageal lumen because the primary peristalsis has not been able to clear the contents out. So there is a mechanism in the esophagus which allows for a secondary peristaltic wave to be initiated, which then propels the bolus downwards. Okay. So important entities are maybe reflux or retained contents which initiate a secondary wave of peristalsis, and this is called secondary peristalsis and not the primary peristalsis. Okay. So primary peristalsis is what we see on a manometry. Correct. So when somebody has taken a bolus of liquid, what happens to the esophageal peristalsis is what we see. Whereas in an endo flip, there is no swallowing that we ask the patient to do. We in fact inflate a balloon, a special balloon at the bottom, and that initiates a secondary peristaltic wave. And we are actually seeing for secondary peristaltic waves when we are doing a endo flip. It's quite possible that few of these motility disorders or few reasons of dysphagia may be problems with secondary peristalsis and not primary peristalsis, right? So this avenue, this modality gives us another angle through which we can assess the esophageal function. Okay. So endoflip is a machine which looks just like a manometry machine. Just that the catheter is slightly different. At the catheter, there is a special balloon which has unique properties. Okay. This balloon can be filled with a certain kind of a conductive fluid. It's a proprietary fluid. We don't know what exactly it is. There is a pressure transducer at the end of this catheter, and like a impedance catheter, there are also multiple impedance sensors within this balloon. Okay, so this balloon can be inflated, and it's a very compliant, it's an infinitely compliant balloon which is inflated with a certain liquid, and then we see for the secondary peristalsis. Okay, so this is how it goes in, and this is how the balloon is there inside. It's just like the pH catheter that we place in. Similarly, we place this catheter or like a nasogastric tube that we place in. There is a 16 centimeter or a longer balloon, which is, or a smaller or a shorter balloon, the 8 centimeter balloon, which is also available, which can be placed across. Usually 16 centimeter balloon is used because it allows for assessing the changes in the pressure over a longer distance in the esophagus, right? And you place this across the EG junction. And once you place this across the EG junction, you start inflating the balloon with various volumes of liquid. And at various volumes of liquid, you give certain time to see what is happening, to see what waves are being seen. Around 60 seconds, you start observing at 40 ml, 50 ml, 60 ml, and 70 ml. And once you inflate it at 70 ml, you again bring it back to 60. And at 60, usually this is the point where you see or assess for the various metrics. Okay. The various metrics that are assessed when you do an endoflip is the distensibility index, that is a DI. You see for the diameter of the lumen, you see the intra-bag pressures, and you see for any contractility or any contraction waves that you can see in the esophagus above, and some of these contractions are unique. They are called repetitive antegrade contractions or repetitive retrograde contractions. Okay, so these are the unique type of contractions which have been labeled. Okay, so how this balloon is different is that it is actually a very, very compliant balloon. Now, suppose if it were a latex balloon. So the what we are interested in seeing when we are inflating the balloon is to see the pressure changes within the esophagus. Correct? So whenever we are, suppose we were inflating a latex balloon over here. So here what is happening? You are increasing the volume of this balloon, and the pressure is also increasing within the balloon in the same proportion. So whatever pressures you will be seeing would be the pressures of the balloon, right? In this case. But see what is happening with the flip balloon. Here you are increasing the volume. The pressure within the balloon does not rise. Okay, so you're increasing the volume in the balloon, the pressures in the balloon do not rise. So whatever pressures you are seeing are the pressures which are generated in the esophageal lumen and not because of the balloon. That is why you are using an infinitely compliant balloon. So that is a speciality of this balloon. It's not any routine balloon. Okay, so that's very, very important. Why this is important? Because you are assessing something called compliance. Compliance is basically the distensibility of the esophageal lumen. Researchers, many of them, believe that the problem in dysphagia might not be actually related to the motility of the esophagus. It might be related to the distensibility of a certain part of the esophagus, right? So compliance or distensibility is volume upon pressure. Okay, so how much volume was used or how much cross-sectional area has been achieved upon the pressure. So FLIP actually analyzes the relationship between luminal cross-sectional area and pressure, which actually provides a measure of distensibility of the esophagus. Right? Simple? Okay. So basically, we now know that the EGJ, esophagogastric junction distensibility index, normally is more than 2.8 millimeters square per millimeters of mercury. So just to simplify things, whatever you're seeing at EGJ distensibility index is sort of a correlate of an IRP. In manometry with IRP, you're trying to make an assessment how well the LES is relaxing. Correct? Similarly, with the endoflip, you're trying to make an assessment how well the LES has the capacity to relax. In simplified terms, it's just by looking at a different angle of that prospect. So this is very important, EGJ distensibility index. We'll come back to that later, how it is used. Now, this EGJ distensibility index, apart from that, the previous versions of the flip, that is the flip 1.0, could give us only basic information like the EGJ distensibility index, which was actually this cross-sectional area, which we, if you represented it in a 3D diagram, it would appear something like this. And you see these beautiful 3D images when the esophagus is contracting, right? This was seen in the flip, only this was seen on the flip 1.0, and this is called as a flip planimetry. Okay, but now with the flip 2.0 software, you also have something called as a flip panometry. Okay, so flip panometry is a very dynamic kind of a flow where not only the three-dimensional rendering, but you see the entire movement of the esophagus or the contractility of the esophagus starting from top to the bottom on a entire chart, like as you do in a manometry. So it's a real-time diameter and distensibility estimate. Okay, the difference here is, so when you see a manometry, on manometry, when you see the scales, you are seeing the pressures. Correct? On manometry, the cooler colors indicate lower pressures. The warmer colors indicate higher pressures. Right? On an endo flip, what you're actually seeing is the diameter. You're not seeing the pressures, you're seeing the diameter of the esophageal lumen. Okay, so here the warmer colors indicate lesser diameter and the cooler colors indicate greater diameter. Okay, so if you see this chart, so this is the original state of the esophagus. The LES is closed. Okay, you see the black colors, the red colors, warm colors. Okay, the diameter is lesser. As you are going, as you are inflating the balloon, it seems to be opening up, the diameter seems to be reducing, and it's opening up. So basically on an endo flip, you are seeing the diameters. Okay. So two things as we discussed. One is that it shows the EGG distensibility index, and these waves that we see, as you saw previously, these waves here are actually telling us about the peristalsis that is happening at the top in the esophageal body. But mind you, these are not the primary peristaltic waves, these are the secondary peristaltic waves which have been initiated because of the distension of the balloon that we do at the esophagogastric junction. So it will tell you two things: whether the EGG distensibility and diameter is normal, and second, whether the esophageal, the secondary peristalsis, whether these patterns that you see are normal or abnormal. Correct? So now we have cutoffs. So most of the studies have tried to give cutoffs. A distensibility index of less than 2 is abnormal. A distensibility index of more than 3 is normal. And between 2 and 3 is the gray zone. Okay, so we are talking of the distensibility index at 60 ml of volume of the balloon that is inflated. Okay, so if we talk of the contractions, if we talk of the secondary peristalsis, there is an important concept called repetitive antegrade contractions, RACs, which I previously discussed. So what are RACs? RACs are more than or equal to 6 consecutive antegrade contractions which are more than or equal to 6 centimeters in axial length and which occur at a frequency of 6 plus or minus 3 antegrade contractions per minute. Okay, so when you see this pattern, that is more than or equal to 6 antegrade contractions, more than or equal to 6 centimeters in axial length, and which occur at a frequency of 6 plus or minus 3 per minute, these are labeled as RACs. So why RACs are important? An important study which was published in 2020 showed that if you see RACs, it is very likely that this is normal. So when they saw this in around 160 patients, people who had RACs, 19 out of these 20 patients were asymptomatic. They had no motility disorder. Whereas when the RACs were absent, these were all patients with achalasia cardia. Right? So RACs are an important thing to be seen when you see a endoflip. Okay. So you have done an endoflip and you can see different patterns. So there are some correlates that can be seen in this picture. The upper panel shows you the conventional manometry tracings, and the lower panel shows you the endoflip tracings. Okay. So a patient with normal peristalsis, here the distensibility index would be normal. You see things opening up here and you see repetitive antegrade contractions. This is a patient with type 1 achalasia cardia. Here you see the distensibility index is very poor. It's not opened up and you see absent contractile response. This might be very useful in certain situations. I'll come to a case scenario later. In patients with type 2 achalasia cardia, here you see again the distensibility index is poor. The contractile response is not, very orderly like a repetitive antegrade contractions. It appears very disordered, right? In a patient with type 3 achalasia cardia or a spastic motility disorder, the distensibility index is poor and you see repetitive retrograde contractions. In this, you see how the contractions are going, in a retrograde fraction. We don't know, I mean, how what is the clinical relevance of, because we always thought that peristalsis is always antegrade, but do we have secondary peristalsis which go back retrograde, right? And in patients, and this is an example of a jackhammer's esophagus where you see the distensibility index being okay, but you see strong occluding contractions in the esophageal body with shortening of the esophagus, right? So you've done a flip topography and you see that the distensibility index is less than 2 and diameter is less. This is definitely abnormal. The distensibility index is more than 2, the EGG diameter is more than 16, and you see repetitive antegrade contractions. This is definitely normal. These can be labeled as definitely normal. There will be a subset of patients which lie between both, and these are the patients which don't classically fit into normal or abnormal, and you need to investigate them further, right? So this is what we know as of now with an endoflip. Okay. So I'll just give you some simple examples of endoflip. So this, I think most of us or many of us would have come across such kind of patients in routine practice. A patient with dysphagia to solids and liquids. You see a dilated esophagus. There is some pooling of fluid and food, but on retroversion, you feel the LOS is slightly tight, but you're not very sure, but there's no organic problem there. You do a manometry, the IRP is not more than 15 or not more than the cutoff that we expect, but there is absent peristalsis. So is this a patient with absent peristalsis or type 1 achalasia cardia? This is a common conundrum that we face. There is an entity called achalasia cardia with low IRPs, but we are not very sure whether this will be fitting into a type 1 achalasia cardia or a patient, or we label this as absent esophageal contractility. How do you assess this patients further? As of now, what we do is that we might do a timed barium esophagogram, or maybe you do some provocative test like a rapid drink challenge or something, right? But here, this endoflip might really be useful. You do an endoflip and you see that the distensibility index is very poor and there is absence of contractions. So because the distensibility index is poor, this is actually type 1 achalasia cardia and not just absent esophageal contractility, right? So another example, a patient with suspected achalasia, many times we see that patients are not willing to get the manometry done, or they're not able to tolerate the manometry. When you do the endoscopy on a sedated patient, there itself you can use the endoflip and diagnose it while you're doing the endoscopy. And not just that, when you're doing the poem, so even experienced operators, when they are doing the poem, whether you have completed your myotomy, sometimes is doubtful, right? So endoflip serves a very useful purpose of real-time assessment of analyzing whether you have completed your myotomy or not. When your distensibility index improves, and I think the manufacturer gives you a recommendation of a delta change in distensibility index of maybe 3 or 4. I'm not very sure of that, but a certain variability, a certain change in distensibility index is must to say that you have completed the myotomy, and there are studies to show that this is an adequate myotomy. So you can do a pre-poem and immediately post-poem flip to assess whether you have completed your myotomy or not in the same setting, okay, immediately. So we all know about EGJ outflow obstruction. So here again, the Chicago 4 has been very clear that you don't label a patient who shows a manometric, graph which is suggestive of EGJ outflow obstruction. Don't label him outright. You need to do an adjunctive test to this. And again, here endoflip might be a very, very useful test. If you do an endoflip, what you would see is that the secondary peristalsis would be intact and the distensibility index would be low. The peristalsis here would be intact. So can we use an endoflip right after endoscopy and do away with manometry? That would be a question that we'll have to answer in the future, because using an endoflip, if we leave other aspects apart, might really be, quite practical and useful. You're doing the endoscopy and you're doing an endoflip right then and there during the index endoscopy itself. So how well does endoflip do when you compare the same findings with the manometer? So this was an excellent study by Pandolfino and group. So 40 patients underwent real-time flip panometry during their index in endoscopies itself, and 73% of them showed abnormal flip and 20% showed normal flip readings. In those who showed abnormal flip findings, when a manometry was done, two-thirds of them showed major motility disorders. So most of these were all these major motility disorders that we all know. Again, EGG outflow obstruction was seen in a fair proportion of patients. We again don't know whether these are artifacts or all, but what is more important is that major motility disorders form a very major component of all those who showed abnormal endoflip findings. On the other hand, on patients who showed normal endoflip findings, patients who did not have a major motility disorder, even on high resolution manometry, was substantial, right? So it has a good positive as well as negative predictive value when you're using it as a modality to diagnose. Okay, so in current scenario, when we have a patient with dysphagia, the first thing that we usually do, obviously, and that is right, is to do an endoscopy, right? And then we do a manometry, correct? So this involves a change of setup. This also involves a cooling period of say around 30 minutes to 2 hours, because when you've done an endoscopy, you've gone beyond the G junction, you are actually opening up the LES. So you'd like to give some time for the LES to come back. And here, maybe you're dealing with two different people, the endoscopist, and most of the endoscopists might not be very good at doing motility studies. So probably the two people involved, the endoscopist separately and the motility specialist separately, and patient tolerance also becomes an issue in a few of these cases. So can there be a shift in future? There might. You can bring endoflip in between, right? Because it can be done in the same setting. There is no cooling period. The endoscopist himself is doing this study. There's no need for anybody else to come in between. The patient tolerance is also very good because it's a sedated patient already. And then do we need manometry beyond that or not? It might be needed in few cases, but not in most of the cases. Probably you already have an answer with you, right? So this, we might be staring at a future like this if things fall in place, and you can come up, this was a report which I came across. This is how things are reported in few of the centers in the West. You have done an endoscopy and you give a flip report also added to that endoscopy in the same setting, right? So it gives you both the anatomical information as well as the functional information in the same setting. Such a useful thing to do, correct? So the problem in the Indian setup, obviously, there are a few limitations in India. First, obviously, is the cost, the availability, and the expertise. Obviously, the expertise will only come when the availability and the costs are taken care of. Currently, where endoflip is used routinely in the Western centers where manometry is not tolerated, real-time assessment of esophagogastric junction after achalasia treatment, and cases where manometry is equivocal like achalasia or EGG outflow obstruction, these are situations where definitely an endoflip is almost always used. Evolving situations where endoflip is started to being used more and more often to screen for esophageal motility, dysmotility during index endoscopy itself, in patients with GERD or post anti-reflux surgery, in patients with eosinophilic esophagitis, because eosinophilic esophagitis itself will also alter the esophageal distensibility. So again, a very useful test to diagnose for esophageal eosinophilic esophagitis. And there is also something called as a esoflip, which are actually bougie dilatation catheters which have inbuilt impedance. So you can actually make out how much has been the change in the distensibility when you're using those catheters themselves. So that's called esoflip, right? So then let's come to intraluminal impedance as a modality. So impedance manometry, we all know, we have all seen how does a manometry catheter appear. So in a manometry catheter, you have either water dripping out or you have these solid channels which are picking up the change in the pressures. In an impedance manometry catheter, you have additional impedance channels which are also picking up the changes in the impedance in the esophageal lumen. Correct? So when a manometry tells us about the esophageal contractile wave which goes from top to down, the impedance tells about the change in the impedance in the esophageal lumen. So basically it tells us about the bolus transit. Okay. So when you do an impedance, you would see this purple wave preceding the esophageal contraction, which is actually the bolus moving from top to bottom. Okay, so I've just put in a few examples. This impedance manometry is already in the market with most of the solid state manometry catheters. So you have a patient, 19-year-old female with frequent regurgitation. You've done a manometry and the esophageal motility apparently appears normal, and you're not certain what it is. And when you use an impedance, you can actually see the regurgitate coming back, and you can confirm this. Again, a patient with gastric bypass who is having a refractory GRD symptoms and you are not sure what it is, you do a manometry, there's nothing significantly wrong with the motility, with the esophageal motility, and you can use an impedance here and you can actually see that this patient actually has several events where the refluxes keep occurring from the remnant stomach into the esophageal lumen. So there are situations, and I think one of the situations where it will be very, very useful are patients with ineffective esophageal motility. We don't know which patients of ineffective esophageal motility are of clinical relevance. So you do an impedance with them, and when you do an impedance, if you can actually see the bolus being, stuck at certain place or bolus escape being seen on the impedance, might be these patients need further evaluation. I think that is one area where adding an impedance might really be useful. There are other avenues which can be used for assessing esophageal motility. We all know about barium studies. The problem, I think, is the sensitivity and the specificity, and you need a good radiologist to give you a definitive answer on barium, which I think is lacking in general. And I think a manometry clearly, as of now, clearly outscores a barium study in when you want to do a definitive assessment of a motility disorder. And you also have an esophageal transit scintigraphy, which is like just like a gastric scintigraphy. But the problems in an esophageal transit is that there is a significant lack of standardization as of now, and the availability is also extremely limited as of now, right? So, ladies and gentlemen, my take-home message is that there are newer technologies, especially endoflip and multi-channel impedance, which appear promising. They may help in unraveling diagnosis in equivocal cases and improve patient and physician acceptability. However, these technologies are still evolving, and as of now, esophageal manometry still remains the gold standard. Thank you so much.
Thank you, sir. Just as usual, amazing talk, and you made complexity seem simple. So, thank you for the wonderful deliberation on the entire newer technologies which could probably come, and many centers would start using them. So, we'll start with questions in a while, but then there are so many. I'm so excited with so many new physics involved. So, being a physician, to understand so much of physics in itself is a charm in you. So, what is this infinitely compliant balloon, sir? Balloon is a balloon for me, but then yes, you are
So
the.
it might not be infinitely compliant, but its compliance starts at a very later stage, right? So I'll give you an example again. Suppose you have used a latex balloon. We use these latex balloons very frequently when you're doing this anorectal manometry. So this is the latex balloon. You start inflating it with water or any liquid for that matter, and the pressure within the balloon rises because the compliance of the balloon is limited. That means it is not able to take in a lot of pressure for a longer period of time. So it will keep transmitting its own pressure. It will keep generating its own pressure after a certain point. This balloon, on the other hand, you start inflating it, right? Its intra-balloon pressure, the pressure generated because of the balloon is not very significant because of some properties of tensile strength of the balloon. So the diameter of the balloon will increase, but pressure because of the balloon will not rise. Only the diameter will increase. So that increase in diameter, the pressure rise will be that rise which you see because of the esophageal walls in the surrounding, not because of the balloon.
Hmm.
So that is something different in this balloon that they are trying to use.
Yeah, so to imagine also that diameter is increasing, but the pressure is not
Yeah,
generated by
yeah.
the balloon, and it reflects the esophageal
Esophageal pressure.
muscular thing is something which is very interesting. Uh, so how do you place the video manometry, the combo of real-time manometry with fluoroscopy together? Because many times what's happening inside physiologically, we are able to see the pressure readings or impedance readings or the secondary peristalsis through different form of graphs. But time and again, the timed barium swallow or the real time barium swallow which actually happens has many times given very good actual information. So do you feel that as of now we know that we had a talk on manometry and video manometry, that is video manometry is a combination of real time manometry happening with fluoroscopy. So something like that where newer things could be generated where we integrate all the three or four technologies we have. So we see different elements from each.
So it appears like a very, very good and very promising note, but I think this has been in picture since a long period of time, and I think there are practical challenges to do that. So we also, if you ask me, we also tried doing this at our setup. But when you're trying to do that procedure, you need the manometry machine right besides your fluoro machine. And you when put in the catheter, that patient has to be under the fluoroscopy, and you're doing the assessment simultaneously in both, correct? So that became a challenge for us because of fluoroscopy. Obviously, most of the units would be using it for several other purposes,
Absolutely.
like an ERCP, dilatation, so hence and so forth. You're not using it primarily for doing a manometry procedure per se as a protocol. So that was a practical challenge which we faced, right? The second challenge, I think, whatever changes are happening, they are happening very fast. So the bolus moves on quite fast, and the wave also goes. So when you're trying to correlate, it's correlationship at every interval and every second. So you need that frame, uh, uh, like a very slow motion kind of a frame, and that slow motion should also be there on the manometry to assess,
Yes.
what is exactly happening at that point of time, which I think again might not always be practically possible, because the speed at which things are happening in real time may not be very, very conducive to actually make an assessment where how efficient this is. But I'm not very sure. I've not used it myself very frequently, but I think this is what the problem can be or maybe.
Yeah. Cool. So also when it comes to pharyngeal manometry, no, our routine water perfusion, like manometry, the manometry which we're using, when we just pull the catheter, we are able to see what's all happening in the upper esophageal sphincter also quite well. And over time, I think there'll be more on talks on what's happening in the pharyngeal part to see what's happening with the neurological dysphasias and other things. But I felt while seeing this, as of now, it is predominantly going to tell about secondary peristalsis only. So, your take on that, sir? Like, can it probably be included elsewhere with this kind of balloon distension related secondary peristalsis? Any other
No, no,
applications?
I don't think endoflip will be useful for that, because when you're talking of the upper sphincter, it's a skeletal muscle,
Yes.
right?
Mm.
And it does not come under the ambit of secondary peristalsis.
At
The
all.
secondary peristalsis will go on to involve the smooth muscle part of the esophagus. I don't think that will go on to involve the upper one third or the skeletal part of the esophagus.
Mm.
So that was a challenge again when most of the systems that we are using are water perfusion systems, and the upper sphincter, because it's a skeletal muscle there, the changes are much more rapid as compared to a water perfusion, as compared to a smooth muscle, right? The water perfusion systems, when they pick up the data, the information, the rate the rate of pickup is generally slower than a solid state, because in the solid state the sensors are right on the catheter tip, on the catheter itself. In the water perfusion, the sensors are not on the catheter, the sensors are beyond there on the setup that you have on the machine. So
Mm.
there is a lag of information,
Mm.
and in the skeletal muscle the changes of frequency are very fast.
Mm.
So that is one of the reasons why a water perfusion might not be, very conducive for a upper esophageal sphincter. And moreover, because of the water that has been dripping in, the water itself will be an irritant,
Return to the.
and you might not have very, appropriate results with that. But I don't think endoflip will be useful for this purpose, because what you're trying to see is for secondary peristalsis, and I don't think secondary peristalsis has the upper sphincter being involved in either case.
The cases. Good, sir. So I think we'll have so many newer things coming over time, and we'll have a plethora of newer kind of uh, uh, technologies that we might be using. The second challenge, or what I was running in my mind, was when we do an endoscopy, followed by manometry also, it's an awake patient, no need of any sedation. Generally, of course, different setups have different. Some places sedation has become the norm for any endoscopic procedure. So, for doing endoflip, has the patient definitely need to be sedated, or it can also be done in a conscious patient?
So that depends on how you're doing the endoscopy. So you're just putting that catheter through the endoscope in the esophageal lumen. So patient, if it is sedated, you can do it at the same setting. If the patient is not sedated and you're doing the manometry, you're doing the endoscopy like that, you can still do the endoflip like
Okay,
that.
so endoflip, it doesn't mean that sedation is generally as
No,
absolutely
it
required.
doesn't take much time and it's quite convenient also. It's not a very difficult thing to do.
Cool, cool, sir. I think I'll start taking some questions which are there in the chat box. Yeah, we have few questions. Yeah. So Dr. Kondala Rao Yedupati has a question. In OP, sometimes we will see patients telling dysphagia. Endoscopy is normal and manometry is normal. How to approach these cases?
Yeah, so this is quite a practical question, and this does happen. So I think one of the things that I would definitely do is that I would always take esophageal biopsies also in these patients because eosinophilic esophagitis is a possibility in these patients, in a few of them. Okay, so eosinophilic esophagitis will not always show findings on the endoscopy. There is, I think, 15 to 20% of the patients with eosinophilic esophagitis will have an absolutely normal appearing mucosa. So during endoscopy, I will definitely take mucosal biopsies. Second, I'll go back and check that manometry has been done correctly or not. And then, if it has been done correctly, you can use some provocative maneuvers. Like there are a subset of patients who say they have dysphagia to very specific foods, like solid foods or cold foods or warm foods. You'll try to replicate that scenario and see if that happens, right? There are certain motility disorders, especially the spastic motility disorders like DES or jackhammer, which might not continuously be present. These are aberrant events. Okay, so if the pretest probability is very strong, if you are very convinced the patient is having classical symptoms that the patient reports, you might go back and do this test again, or you use a provocative test. And when all these tests are normal and you are very assured, then these patients are patients with functional dysphagia. There's an entity called functional dysphagia where everything is normal. As of now, we still don't know what is the reason for functional dysphagia, and you will treat them as a functional patient as of now. But probably these newer tests might just throw up some more information that are we missing out on certain entity which is not being picked up with the currently available tests.
Absolutely, sir. Well answered. In fact, I recently able to recall a patient where endoscopy was normal, and then but classically was telling he had dysphagia and dysphagia and dysphagia to solids. So even on manometry, it looked normal. But then somehow the patient went to a neurologist, and we have Nimans over in Bangalore. So it was later through some channel tests they had diagnosed him to have bulbar myasthenia gravis, and then he was put on pyridostigmine and he's actually doing well. So of course many times we would have some newer things coming up like this, so that's always
Yeah,
there.
and so when you assess a patient with dysphagia, I think the first important thing would be starting from the history itself. So you need to make the distinction, are we dealing with an oropharyngeal dysphagia or an esophageal dysphagia? So if the patient has some change in voice, nasal regurgitation, difficulty in initiating the swallow, very likely that you're dealing with a patient with oropharyngeal dysphagia, and we tend to miss it very frequently. In those patients, obviously your manometries will not pick up anything, and you might have to do something else, like a video fluoroscopy, right? And I think yes. So first we need to assess whether we have done the right assessment. And if we have done it correctly and we have done these newer provocative tests and all of them come negative, you can label these patients as functional dysphagia.
So before functional we should really work
Yeah,
up
do a thorough assessment. Yes, you
thorough.
need to be very certain. Yes.
Absolutely. Then we have Dr. Krishna Sai Pavaluri. She has a question. How useful is barium swallow in dysphagia evaluation, sir? Should it be done routinely in all patients with normal endoscopy and before esophageal HRM, or any specific scenario where it is more useful?
So if you ask me, We have practically stopped doing barium for patients with dysphagia. Many people might not agree, or many centers might not agree. They might still be using barium, but I think it also boils down to the local expertise of what is available with you and how confident you are on the manometric diagnosis. If you are with a good manometry established practice at your place, there are still situations where barium might be useful. This I find useful if you have some problems in the upper esophagus, like a Zenker's diverticulum or a cricopharyngeal bar. When you're trying to make an assessment of the length of stricture of the esophagus to plan any further therapy like stenting or dilatation, or when you have seen that patient has a spastic motility disorder, like maybe a type 3 achalasia or a DES or a jackhammer, where you want to actually see how much is the length of the contractile segment, because that I have to be very sure if you're planning to do something like a poem, because then you would want to involve the entire spastic segment in your myotomy. So I think these are these three or four situations where I do still go ahead with the barium. Otherwise, practically, in almost all cases, manometry is good enough to give you a definitive answer.
Good. Nice. Sir, this RAC and RRC, a little more information on these two things. But they made a lot of meaning to us, definitely. But then conceptualizing is becoming difficult.
So even I think even I'm not very sure of what it actually means in terms of pathophysiology or physiology. But RACs, I think, tells you the normal phenomenon that is happening in the esophagus. And RRCs are not the normal phenomenon. They are abnormal waves, which would be seen in certain situations. That is the only thing I can practically tell you as of now. But if you, I'm not very sure of the pathophysiology. I think time will tell us, or maybe more studies will tell us later on.
Absolutely. So, because when you spoke about achalasia type 3, there was drastic difference in the direction of the entire thing. So, I was like little perplexed there. Even in jackhammers, when you showed the picture, it like made a huge difference because just increase amplitude, but there's more to that. So,
Yes.
anyway, it all are even thought processes and learnings are evolving. Next, Dr. Prashanth Gopal has a question. Can this be used across the pylorus for diagnosis of gastroparesis?
Yes. So definitely it has been used. Endoflip has been, there are studies where endoflip has been used to also make an assessment of the pyloric sphincter. So basically areas which have a sphincter,
Think.
especially the G junction and the pylorus, endoflip is used. And I think it is also based there also on the similar principle of distensibility. Yes.
True. So we might even have for Hirschsprungs or
Harsh.
some wherever there is sphincter and we don't expect, we might get more validation over time. So Dr. Krishna has a question. Is endoflip done in supine or sitting position?
Yeah, so in the same position where you're doing the endoscopy,
Upper GI scope.
left lateral or supine, not in the sitting.
Okay, cool. So I think almost 1 hour is almost up. We'll have just some small time. Yeah, we have some suggestions for next talks. So, thank you, sir. It's been amazing. And actually, we are trying to digest the concepts actually, and you really made it quite easy. If I had read a journal or texts on neuromotility on this thing, probably it would have taken some months to really digest. So you have concised it for us to actually, go read up what's exactly happening in this newer technology. And over time, I think. All of us would have more patience, data, validation, calibrations that's happening for our population to really tell the same thing what happened with manometry. We now have Indian nomograms, so we're expecting huge things to happen in most of the newer ones which are coming. So thank you for taking and giving us a good knowledge on these newer ones, which slowly will penetrate all centers, is what I would uh, think of. Thank you, sir. Thank you for accepting this invitation also.
Thank you. Thank you, Prashant, for having me here. Look forward to attending more of your meetings in the future. Thank you so much.
Our pleasure, sir. Thank you. So, to all our viewers, the next talk would be very interesting and practical. It is about the pelvic floor rehabilitation by a physiotherapist. with a vast experience in various types with different modes of treatment. So stay tuned for that. The dates will be out. Probably it would be within next 2 weeks. So we have got some confirmation there. So in case if you guys have any issues or feedbacks, do let me know. We also have an YouTube channel where these talks would again be put there so that whoever could not attend it directly during live session are able to get adequate nuanced information. Thank you guys. Thank you.